Okay, hello everyone. Welcome to the 16th FARO webinar. I'm Tosol Liu from Dirams in Korea, and will be moderating this meeting today. I would like to begin the webinar by introducing Dr. Imjai Chitaphanaruk, the president of FARO, to whom we owe the honor of opening the webinar with. Dr. Imjai, please.
Hi, very good afternoon and good evening to all FARO officers, council members, educational training committee, and all of the FARO members.
Recording in progress.
This is the 16th FARO webinar hosted by the Korean Society for Radiation Oncology, or KOSRO. It will focus on radiotherapy for one of the aggressive types of brain tumor, atypical meningioma. I would like to thank KOSRO for the cooperation in FARO webinar, the speaker, moderator, and all the panelists from Singapore, Malaysia, and India for giving the time and insight today. And thanks to IROS for continuing support and organize FARO webinar. I wish you all a very successful conference today. Thank you.
Thank you, Dr. Chitaphanaruk. Next, I would like to introduce Dr. Honggyun Woo, the president of Korean Society of Radiation Oncology, for greetings from Korea. And he could not come for some reasons, so I'd like to apologize for substituting with a pre-recorded video of Dr. Woo. Please.
Of June, hosted by Korean Society for Radiation Oncology. It is a great privilege for me to address welcome message today. As all you know, aim of FARO is to foster the role of radiation oncology to improve the basic level of radiotherapy for the benefit of the cancer patient in the Asian region. Since establishment of FARO, our main activity was focused in academic advancement in FARO member countries. FARO successfully held the 5th regular meeting hosted by Philippines last October. The next FARO meeting will be held in Seoul, Korea in October 11th to 13th of 2023. Please make note of this important date. Korean Society for Radiation Oncology is trying to prepare not only a fruitful program, but also various social events. We will make sure you will not forget this amazing experience in Korea. There were already 15 webinars with timely, relevant topics. I believe these scientific efforts affected improvement of radiotherapy in FARO member countries. Taking this opportunity, I'd like to thank the Education and Training Committee for their report. Also, I'd like to thank the corporate members for their support. Please enjoy today's topic, optimizing radiotherapy for atypical meningiomas. Thanks.
Okay, and before moving on the lecture, we will take group photos. And panelists, audience, and all the members, please turn on the camera. And okay, all the panels. Okay, if everyone's ready, we'll take a photo.
Yes, okay. I'm Maisa. I will help you assist in taking photos. Kindly open your cameras, please. Okay. So I will take the photo on the count of 3. 1, 2, and 3. Smile. Okay, the photos has been taken. Thank you. Back to you, Dr. Wu.
Okay, thank you. And now I will invite our speaker for today's lecture, Dr. Chano Wee from Korea. He graduated from Seoul National University College of Medicine, studied radiation oncology in same hospital. And he had worked as assistant professor in Bundang Seoul National University Hospital, and now he's an assistant professor in Seoul Borame Hospital and Seoul National University College of Medicine. And he has actively studied brain tumor for many years and has won numerous awards due to the research achievements from KOSRO, Korea Cancer Association, FARO, ESTRO, and so on. So it's my pleasure to introduce Dr. Wee. Dr. Wee, please.
Thank you, Dr. Yu, for your kind introduction. Can I share my slides? Do the slides appear okay?
Okay.
Okay, thank you. Hello, everyone. I'm Chanui from Borame Medical Center. It's a affiliated hospital to Seoul National University in Korea. I first want to say it's a great honor for me to give a talk today at the webinar, and I thank Professor Chita Panarux and Honggyun Woo, as well as the scientific committee of FARO. Today, I'm going to talk about the role of conventional external beam radiation for atypical meningiomas. My talk will probably be more of a review on updates and management in atypical meningiomas. So after the talk, I'll look forward to a hot discussion and some sharing of experience from much more experienced radiation oncologists than me from all over the Asia. Okay, so these are my contents for today. As you all know, meningiomas arise from the arachnoid cap cells in the meninges, and it's the most common primary brain tumor, as well as the most common primary benign brain tumor in adults. And the median age of diagnosis is 65 years. And the well-known risk factors for meningioma includes age, female sex, radiation exposure, neurofibromatosis type 2, and female hormone replacement therapy. And with the increasing utilization of MRIs, incidental meningiomas are increasing. And for benign meningiomas, the doubling time usually ranges from 10 to 20 years. I first want to look into the WHO 2021 classification, which was published last year. And there wasn't really many changes for meningiomas, but you can see that for grade 3 meningiomas, there has been 2 criterions has been added for the diagnosis of anaplastic meningiomas. So if you look at grade 2, which includes several histologic subtypes, but you can just call grade 2 and probably the same word. If you call it atypical meningiomas, you mean grade 2 meningiomas. So for grade 1 and 2, there are more females than males, and for grade 2, if you have mitosis ranging from 4 to 19 per 10 high power field, then you would be diagnosed as grade 2. Or you can have 3 of the following features in pathology: necrosis, high NC ratio, prominent nucleoli, sheeting, hypercellularity. If you have 3 of those, you'll be diagnosed as grade 2 meningioma. And starting from 2016, direct brain parenchymal invasion makes you grade 2. And for grade 3, if you have mitosis 20 or higher, or you have an absolute anaplasia, or if you have homozygous deletion of CDKN2A or 2B, or TERT promoter mutation, you would be directly just diagnosed as grade 3. And if you look at the 10-year outcomes, just briefly, grade 1, the outcomes are very good, and grade 2, atypical meningiomas, the progression-free survival ranges from 20 to 80%, and grade 3 have a much poorer outcome with progression-free survival of almost 0%. Although CDKN2A or B homozygous deletion and TERT promoter mutation have significant impact on survival, they only account for up to about 10% of meningiomas at most. This is just a brief summary on the management of meningiomas. If the patient is asymptomatic and the tumor is small, you initially get to undergo regular follow-ups. If not, you get surgery, which ideally need gross total resection of Simpson grade 1 or 2, and there's radiotherapy as a treatment option. If you look at the Simpson grading of meningioma resection, which was initially proposed by Dr. Simpson in 1957, Simpson grade 1 to 3 corresponds to GTR, which is gross total resection. And although many studies have emphasized the impact of Simpson grade on tumor recurrence, some people nowadays may argue that evaluating the extent of surgery by just MRI-based GTR might be enough nowadays. And I want to talk about some molecular features of meningiomas. And just like all other cancers, meningiomas also show intratumoral heterogeneity. And this is an example of an intraventricular anaplastic meningioma. When you look at the tumor sections, some areas demonstrate grade 1 histology, whereas some areas show atypical grade 2 or anaplastic histology. And if you look into the copy number profiles, you can see the diversity of the copy number profiles between area 1, 2, 3. And over the past several years, some groups have published some excellent work on genetic and molecular research in meningiomas, mostly based on the methylation and copy number profiles. And this is a work from the University of Toronto by Professor Zade and Aldepe. They have made a methylome-based predictor with DNA methylation and copy number profiles for predicting recurrence-free survival. And by adding the methylome-based predictor and WHO grade and Simpson grade, they have made a recurrence scoring system to divide patients to high risk and low risk for recurrence so that they can guide further management after surgery. And I have heard that this scoring system is used to guide whether you will proceed to postdoc radiation in Princess Margaret Cancer Center. The same group have expanded their work and published it in Nature last year. In this paper, 4 molecular classifications of meningiomas were established based on the copy number alteration, point mutations, methylation, and mRNA abundance. And you can see that between those 4 molecular groups, there is a significant survival difference. Also, the European group has done some similar work based on methylation profiling. And as you can see here, NF2 mutation and chromosome 22q deletion is a very important genetic change in meningiomas. Based on that work, the German Consortium on Aggressive Meningiomas have shown some important prognostic copy number alterations, such as loss of 22q or 1p, 6q, 14q, and 10q losses. And also Professor Wenya Linda B. from the Harvard group in Brigham and Women's Hospital has done some wonderful job focusing also on copy number alterations. They found out some key molecular alterations, and by adding the mitotic counts to those molecular alterations, they made a 3-tiered integrated grading system. And so if you see here, that you can see that especially in WHO grade 2 atypical meningiomas, they are reclassified to either grade 1 or 2 or 3 according to this grading system. And according to this grading system, you can see that the progression-free survival significantly differs. And they have shown that this integrated grading system compared to the WHO grading system is much more accurate and as time goes by, it is it becomes more accurate to predict progression-free survival in patients. One interesting finding from the study is that radiation-induced meningiomas have more aggressive, high-grade molecular features compared to sporadic meningiomas, although they histologically look like grade 1 tumors. So you can see here, this is the radiation-induced meningioma data, and among the histologically grade 1 tumors, most of them are reclassified as the integrate grade 2. So they harbor more aggressive molecular features than non-radiation induced meningiomas. The Baylor College group has also shown that after complete resection, only patients with all three of NF2 mutation and 22q and 1p loss experience recurrence, and other patients do not recur after complete resection. And tumor location is also important. So if you go towards the skull base, such as the olfactory groove or clinoid or planus sphenoidal, most of the tumors show benign features. And if you go more posteriorly and laterally, such as the lateral convexity or falcian or parasagittal, you get to have more high-grade aggressive tumors. So now we know more about the impact of molecular features in meningiomas. Then the next step for radiation oncologists should be identifying the candidates who would really benefit with adjuvant radiotherapy, and whether to how to individualize the indication of post-op radiation based on these molecular features. We have to have more data, and we have to have more evidence to guide radiation based on this, because some neurosurgeons believe that if you have a very aggressive molecular feature, the patient will not do well no matter what kind of treatment we offer. And some neurosurgeons, on the other hand, believe that if the patient have high risk molecular features, then you have to escalate and intensify the treatment, such as offering post-op radiation or something else. Now I'll talk more about radiation. So why do we have to consider radiation after surgery in meningiomas? It's because in grade 2 or 3 meningiomas, after surgery alone, almost over 50 to 100 patients get to experience tumor recurrence. We can consider radiation in non-surgical cases, post-op cases, and salvage cases, whether it's a re-irradiation or not. And we have SRS and conventionally fractionated radiotherapy for our EBRT modalities. And today I'm going to focus on the post-op conventional radiation. I think everyone agrees that you need post-op radiation after surgery in anaplastic meningiomas, which is WHO grade 3. And if you look at the National Cancer Database, post-op radiation provided a significant overall survival benefit. And even after GTR, post-op radiation provided overall survival benefit. So it's not the anaplastic meningiomas we're concerned about. It's the atypical grade 2 meningiomas, especially those who have complete resection, where there's a lot of controversies in terms of the role of post-op radiation. In this study, similarly, using the National Cancer Database, you can see that there is an overall survival benefit with radiation in patients who have residual disease after surgery. That's subtotal resection. But however, for patients who got complete resection, there was no overall survival benefit with post-op radiation in atypical meningiomas. Currently, the NCCN guideline and the European EANO guideline indefinitely recommend post-op radiation after complete resection in grade 2 atypical meningiomas. So you can see that in grade 2, if you get complete resection, you can consider radiation. And in the EANO guidelines, in grade 2, get GTR, you can either go observe the patients or you can do radiation for the patient. Unfortunately, there are no published prospective randomized trials looking into the role of post-op radiation after complete resection. And there are really lots of retrospective studies have shown very conflicting results on the role of radiation after GTR. So like this study in the UK multi-center study and the Mayo Clinic series, they showed no benefit with radiation in terms of overall survival or progression-free survival. But you can see that the number of samples, the sample size is relatively small. And with a larger patient number, the Chinese group and the British Columbia group also shows there is no survival or local control benefit with post-op radiation after GTR. However, although there were some discrepancies in patient characteristics between the radiation group and the no radiation group, they have not performed a multivariate analysis to adjust for other important factors such as surgery, whether it's GTR or subtotal resection, or tumor size, or mitosis, or Ki-67 index, etc. So you cannot just go on and say there is no benefit with radiation after GTR. And in contrast, of course, a lot of studies, some of them shown here, such as the Memorial Sloan Kettering data or the University of California, San Francisco data, also show that there actually is a local control and progression-free survival benefit with post-op radiation even after complete resection. However, you can see still the sample size is quite small. And also some recent meta-analysis also show that there is a benefit with radiation after GTR, but this is just a meta-analysis. And if you look at the MGH data, they have shown that after propensity score matching, there is a progression-free survival benefit with post-op radiation, even after GTR. Actually, there was only a small number of patients who received radiation in the MGH data. So including me, and we performed a multi-center study in Korea with patients from Seoul National University hospitals and Yonsei University. This study included 4 hospitals from the 2 universities, and we had, as far as we know, this is probably the largest retrospective series for atypical meningiomas. We included over 500 patients, and among those, 158 patients received post-op radiation. We looked into local failure and progression or recurrence rate and progression-free survival. We also performed the propensity score matching, and we performed a recursive partition analysis in terms of progression or recurrence. The median radiation dose was 59.4 gray in 33 fractions. As we expected, there was a very significant difference between the radiation and the no radiation groups. The tumor size was significantly larger in the radiation group, and there were more GTR patients in the no radiation group. And also the Ki-67 index, proliferation index, was higher in the radiation group. Before propensity matching, score matching in the entire cohort, with a median follow-up of 65 months, there was, of course, there was a progression-free survival benefit and tumor control benefit in patients who received subtotal resection. But you can see that there is only a trend towards improved progression-free survival and progression-free survival and tumor control rates in patients who underwent GTR. So we performed a multivariate analysis adjusting for size, surgery type, radiotherapy significantly improves progression-free survival and improves tumor control. So then we did a propensity score matching analysis, and in the propensity score matched cohort, you can see that progression-free survival and tumor control is all significantly improved with adjuvant radiation. And if you specifically look into the patients who underwent GTR, you can see that there is still a significant improvement in progression-free survival with adjuvant radiation in patients who received GTR. And of course, tumor control was significantly improved. So then we wanted to look into which patients are at the highest risk for recurrence if they undergo surgery alone. So with about 350 patients who did not receive radiation and just received surgery, we did a recursive partition analysis to see which patients are at the high risk for progression or recurrence. And based on the surgical extent and the tumor size and the Ki-67 index, we identify 3 risk groups. You can see over here that the recurrence rates significantly differ between those risk groups. So for each risk group, we evaluated the impact of adjuvant radiation. And you can see here, of course, in the intermediate risk or high risk group, the adjuvant radiation improved tumor control. And even in the low risk group, if you add radiation, you had a trend, insignificant trend towards improved tumor control in the low risk group as well. And if you just look into the local failure, then you have a significant benefit with radiation even in the low risk group. So we observed a absolute tumor control benefit with adjuvant radiotherapy, regardless of extent of resection or risk of recurrence. However, unfortunately, in these patients, we did not observe any positive impact on overall survival with adjuvant radiation. There are some prospective non-randomized trials that was published during the past few years. And this one is the RTOG 0539 study. Then, since our focus is on grade 2 patients who receive GTR, they define the group 2 intermediate risk as patients who have recurrent grade 1 meningiomas or newly diagnosed grade 2 meningiomas who received GTR, and then they treated them with for this study, it included atypical and anaplastic meningiomas. And if you have GTR, then you treat them with 60 gray and 30 fractions. And if you have residual disease, you boost 10 gray, additional 10 gray up to 70 gray. And if you look into the patients who have grade 2 and GTR, the 3-year progression-free survival rates were 89%, which is similar to our 5-year 85%. There are 2 randomized trials ongoing now to look into whether adjuvant radiation after GTR might improve progression-free survival. One study is from the NRG group and one study is from the Rome and the EORTC group. They are testing adjuvant radiation around 60 gray after GTR, and we have to wait for these results to come out, but it might take a very long time. Although there is only local control or progression-free survival benefit with radiation in grade 2 tumors, and there is no overall survival with radiation, it is really important to control the tumor, because once the tumor relapses, the survival is very poor compared to newly diagnosed cases. Then what is the optimal radiation dose in atypical meningiomas? Currently, the NCCN guideline recommends 54 to 60 gray for atypical meningiomas. As I said, 60 gray is used in the ongoing NRG trial and the EORTC trial. But nobody knows whether this dose is enough for tumor control or not. We first have to know the alpha-beta ratio of meningiomas. And if you look at the alpha-beta ratios that came from the benign meningioma SRS series, it ranges between 3 to 4 gray, which is lower than glioblastoma or other cancers. And although there is no data for atypical meningiomas particularly addressing the alpha-beta ratio, we can assume that the alpha-beta ratio in atypical meningiomas might not be that high, as such as 10 gray or something. In the National Cancer Database, they evaluated the radiation dose response relationship, and with a cutoff of 54 gray, there was no overall survival benefit with higher doses. But however, in the SRS series, for example, this one is from the University of California, San Francisco, the tumor recurrence rate was reduced by 42% per every 1 gray increase in the SRS dose. And in some proton series with conventional fractionation, patients receiving higher doses over 60 gray showed improved cause-specific survival and also local control. So we wanted to analyze the dose-responsive relationship in our SNU Yonsei data in 135 patients. The median RT dose was 60 gray and 30 fractions, ranging from 45 gray 15 fractions to 66 gray 30 fractions. And we calculated the EQD2 based on the alpha-beta ratio of 4 gray. And if you compare the patient characteristics between the high dose group and the low dose group. The high dose, we just defined the high dose as over EQD2 of 57.42 gray, which corresponds to 59.4 gray in 33 fractions, which is a very often used dose scheme for meningiomas. And there was no significant difference in patient characteristics between the groups other than the mitosis. And then we performed the multivariate analysis, and for local failure, progression-free survival, and overall survival. Interestingly, there was no actual impact of whether you receive GTR or subtotal resection. Instead, the tumor size and the mitosis and the radiation dose as a continuous variable, the EQD2 was a really significant factor for local failure, progression-free survival, and overall survival, all three of these endpoints. So per 1 gray in increase in EQD2, there was that led to 12% reduction of local failure and 12% reduction of failure or death and 16% reduction of death. And we wanted to find out the optimal cutoff for the EQD2, but using various cutoff values, we just saw that the EQD2 is very significantly important anyways. So, and then we did this plot adjusting for the cofactors. You can see that there is no optimal cutoff, and as higher dose you deliver, the risk of local failure and progression-free survival and overall survival all decreases. So we observed this dose-responsive relationship in atypical meningiomas, and actually there are several published dose escalation studies which tested a dose escalation up to around 68 gray using particle therapy. You can see that the small number of patients is very small. However, the local control rates were excellent, with over 80% to 100%, and the overall survival was also excellent with dose escalation. There are several ongoing prospective trials looking into dose escalation. The Heidelberg group is testing a carbon ion boost up to 68 gray after photon therapy of 50 gray. And the MGH group is testing a IMPT dose escalation. And the Dresden group in Germany is also testing a proton beam boost up to 68 or 72 gray. Some groups have tested lower doses using moderate hypofractionation. And in this Emory series, which exclusively included benign meningiomas, the Emory group showed feasible outcomes in with 30 gray and 10 fractions, leading to a local control of almost 100%. This one here is a schwannoma, it's not a meningioma recurrence. However, the Princess Margaret Cancer Center data, which included some grade 2 or 3 meningiomas, they used a 40 gray and 15 fractions, and you can see that the progression-free survival for grade 2 or 3 tumors is extremely short. So lower doses does not work as well. You can see here. There are also some issues regarding the target volumes for atypical meningiomas. Although we do not have a definite answer now, there are variations of margins from the GTV and whether you have to include the dural tail, which is mostly a reactive process of vascular congestion or edema. Of course, there can be some tumor invasion as well. Now the energy RTOG protocols do not include the dural tail in the GTV, and the EORTC protocols actually include the dural tail in the GTV. So there's some controversy here. And you can get some help from PET, since meningiomas overexpress somatostatin receptors. You can use gallium dotatate or gallium dotatate PET for evaluating the extent of tumor and response evaluation after treatment. So this is an example here. You can see the three small enhancements on the MRI, and you cannot really tell which one is a tumor and which one is a vessel. But if you use the dotatate PET here, then you can see that the one in the middle is actually a vessel, and these two are actual tumors. And you can also use dotatate PET for accurate evaluation of how much the tumor is extended through the falcine, like here. And also, this is an example of PET being useful to identifying bone invasion of the tumor. This is a post-op MRI of a patient, and you can see over here there's some enhancement, but the radiologist gave you a post-op granulation tissue or inflammation or something. But if you use PET, you can see that there is actually a residual tumor in the bone. So that can help to guide you delineate your target volumes accurately. Lastly, I want to talk about some hematologic biomarkers in atypical meningioma. This is probably a very minor field of investigation in meningioma, since almost surgery and radiation is everything you can do for meningiomas. And the fibrinogen and neutrophil to lymphocyte ratio is a very famous hematologic biomarker you can obtain by simple blood tests. And you can see that if you have high levels of fibrinogen, it might help tumor cells with adhesion or migration, or give them some protection from your NK cells. And in the clinical data in colon cancer and gastric cancers, you can see that if you have higher fibrinogen levels, you have poor survival. And this is a much more famous biomarker, which you'll probably all know, that high neutrophil to lymphocyte ratio, which might reflect the adverse anti-tumor immune reservoir. And you can see almost in all types of cancers, if you have this, then you'll have a poor survival rate. So there are some studies looking into those hematologic biomarkers. This report was from China. It included 163 atypical meningiomas, and they looked into the preoperative fibrinogen and neutrophil to lymphocyte ratio. You can see that combining these two and if you make a scoring system based on that, you can see the progression-free survival significantly differs based on those biomarkers. And this one is the data from Keio University, including 160 meningiomas, which were most of them were benign meningiomas. If you look at the preoperative neutrophil to lymphocyte ratio, if you have a higher ratio, then you'll have a poor progression-free survival. And that was still valid when it was adjusted for WHO grade or surgery type or anything in multivariate analysis. And this one's from Princess Margaret Cancer Center. You can see that if you have neutrophilia before surgery, then you have a poor recurrence-free survival compared to those who do not have neutrophilia. And that is still valid in the multivariate analysis when you still adjust for the tumor grade or extent of resection or tumor size. This one, some might be familiar and some might not. It's called the Radiasi ratio. It's the ratio between AST and ALT, with which everybody would know. These are the two famous liver enzymes you can very easily obtain through simple blood tests. And the AST exists in the mitochondria, so not only the liver, but it exists in the heart, kidney, brain, skeletal muscles, and everywhere. In the other hand, ALT almost only exists in the hepatocyte cytoplasm. So these two are not really the same enzymes as we think. And since cancer cells highly rely on glycolysis for their metabolism rather than the TCA cycle, and the AST, it's a component of the malate aspartate shuttle pathway. It plays an important role in aerobic glycolysis. So it has correlations with cancer cell metabolism, and just simply the ALT to meet the metabolism demand of tumor cells. If the ALT is lower, then it's more advantageous for the tumor cell metabolism. So this the Radiasi ratio was also evaluated in various cancers such as urothelial carcinoma, renal cell carcinoma, prostate cancer, head and neck cancer, liver cancer, etc. And if you have an increased Radiasi ratio, then you have a poor overall survival and poor cancer specific survival and poor recurrence-free survival. So we looked into the hematology biomarkers in the SNU and Yonsei data, and we did another collaboration with Keio University. And we saw in the whole cohort that the Radiasi ratio was a very negative factor for tumor control and progression-free survival. But very interestingly, if you look at the patients who received radiation, then the prognostic significance of the Radiasi ratio is gone, and suddenly the neutrophil to lymphocyte ratio becomes very important. And if you look at the patients who did not receive radiation, then the Radiasi ratio is still important, and the neutrophil to lymphocyte ratio is not. So we thought that based on these findings, that post-op the Radiasi ratio may represent some residual tumor cells, whether you received GTR or STR. And since the Radiasi ratio was not significant in the patients who received radiation, we thought that post-op radiation might have successfully eradicated the residual tumor cells after surgery. And since neutrophil to lymphocyte ratio is an important factor in patients who did radiation, we thought that the anti-tumor immune response would be more important for the radiation to kill the tumor cells. So that that's almost it for my talk today. And in conclusion, the molecular features based on the methylation profiles or copy number alterations might give us further insight beyond the WHO grading system in meningiomas. And adjuvant radiotherapy in atypical meningiomas is very important for tumor control and improving progression-free survival, regardless of surgical extent. And to some degree, dose escalation with or without particle therapy might further improve tumor control in atypical meningiomas. And hematologic biomarkers may identify high-risk groups for recurrence and predict the response to radiation as well. And lastly, I want to say that I think it would be very important moving forward if all the countries and centers in the members of FARO do a lot of collaborative works, then we might have very meaningful results and productions. I want to thank Professor Hong In Yoon. He had collaborated with me for most of the work, and I want to thank Professor Hwa Kyung-byun and Won-ik Chang. They did almost all the data collection and the writing, and also our teachers Irang Kim, Ina Kim, and Chang Ok Seo, who have treated most of the patients included in the studies I showed, and my colleague Professor Chu-ho Lee as well. And moving forward, we are conducting some collaborative work with the Catholic University of Korea, Professor Won Mo-sung, and the MGH group, Helen Shi and Clemens Grasberger. So that's it for my talk, and thank you for your attention.
Thank you, Dr. Wee, for your remarkable and very informative speech as always. And next, I would like to introduce the expert panel. Dr. Brandon Chia from National Cancer Center, Singapore, and Dr. Is there here? And Adlinda Ali from University Malaya Medical Center, Malaysia. And Dr. Tepal Gupta from Tata Memorial Center in India. Everyone's there. And I would like to thank the panelists from 3 countries for willingly volunteering to attend today. So the panelists will take turn to make some comments or ask questions first. And in order to earn some time for everyone to think of questions from the floor. And so does anyone from the panels have questions or comments to make? Please.
Yeah. So good afternoon. This is Dr. Gupta from Tata Memorial Center in India. Can I make some comments? Hello. Am I audible?
Yes, we can hear you.
Yeah. So I think very nice presentation. I think a good overview of the sort of molecular changes that have happened in meningioma over the last 1 decade. I think a lot of work has gone in characterizing them molecularly, not only using the methylation, but some other platforms as well. And we now very clearly understand that the histological grading in itself, although it has served us for more than 50 years, that's not necessarily the most robust prognostic indicator as far as meningiomas are concerned. And particularly many of the grade 2 meningiomas, they actually behave much worse and should ideally be considered as grade 3 meningiomas. And as Dr. Chan showed, any homozygous deletion of CDKN2A, B, or third promoter mutation, that automatically now the 2021 classification upgrades them as grade 3 meningiomas. Fortunately, for the most part, most of the meningiomas are histologically grade 1. I mean, the vast majority across all sites, I mean, across all centers across the world. I think approximately 70% of all meningiomas are actually grade 1 meningiomas. And I think one of the challenges that lies is that most of the times, if it's a histologically grade 1 meningioma, the neurosurgeon would not refer that patient to an oncologist. And even if a subtotal resection has been done, of course, many of these patients can be observed with serial surveillance imaging. But I think the involvement of the oncologist becomes important. For far too long, we have considered meningioma as a surgical disease. Extent of resection remains paramount. I'm not trying to suggest that resection should be compromised, but I think more and more involvement of oncologists, the radiation oncologists, and I'm quite sure that in the next decade, you will have a lot of targeted treatments also coming up for meningioma. So I think systemic therapy till now has always failed in meningiomas, but primarily because we didn't understand the molecular biology of meningiomas. So now that we have begun to unravel that molecular biology, it's a matter of time that we will come up with some targeted therapeutic approaches as well. What I wanted to ask Dr. Chan was, from your data, you showed that regardless of the extent of resection, adjuvant radiotherapy improved outcomes. I mean, there is conflicting data. You yourself showed that some of the series did show that there is a benefit in progression-free survival in GTR patients, but other data sets showed that there is no significant benefit. And that is why we have the two ongoing randomized controlled trials. Do you think it's a selection bias? I mean, it's a retrospective data, and that's why you tend to see regardless of the extent of resection, or is it that the rates of GTR are lesser in your series, and that is why it reflects that even more patients are STR, and that's why the overall cohort reflects benefit of adjuvant radiotherapy in your series?
I think just based on our data that after GTR, even regardless of how much proportion of patients receive GTR, I think radiation has a role of tumor control after surgery when you have complete resection. So I tend to just go on to radiation for patients even after GTR. I don't really consider other factors after seeing the data like this.
And do you have the CDKN2A or HTERT or copy number variations profiled from your series, or that's
no. We unfortunately we did not have the data for the past patients, and even now we do not routinely test those markers, unfortunately, for meningiomas.
So I would just like to share our sort of experience as far as atypical meningiomas is concerned, and we also analyzed our cohort, which was published I think a couple of years ago, 2017-18, in Practical Radiation Oncology. So those who received upfront adjuvant radiotherapy after surgery, within 6 months of the primary surgery, if they receive, we label them as upfront adjuvant radiotherapy, versus those who were observed and then irradiated at a later date at progression. And we did see a significant difference in survival between upfront adjuvant radiotherapy versus deferred or delayed radiation therapy. Whether at progression there are additional changes which make the tumor more aggressive, and that is why this difference, or even at baseline, the primary tumor itself was more aggressive, that we really don't know. but we did see that upfront adjuvant radiotherapy reduced the risk of progression and actually improved overall survival in atypical meningiomas.
I think that is probably the same finding from our study, because we defined adjuvant radiation as receiving radiation within 3 months and without any evidence of progression in our study. So I think it's a similar finding.
Also, just last question that I wanted to ask you was, have you looked at the radiomics of these tumors, MR images, and any thoughts of doing a radiomic analysis?
Actually, we are trying to do some things based on those MRIs and radiomics. That was the one I mentioned at the last of my talk, that we are doing some collaboration, but I don't know yet how the results are going to come out. So
yeah, in the last 1 year, I think a few reports and analysis of radiomics in meningiomas predicting not only the histological grade, but also the biological behavior and outcomes has been published. So I look forward to that from you. Thank you.
thank you.
Hi,
Is
Dr.
there
Chan.
any comments or questions from other panel?
Can I be heard?
Yeah, please.
Hi. Thanks, Dr. Chan, for your talk. Actually, it's quite informative. I just within our center as well, we actually had a few questions with regards to your practice, because rightfully you did mention about how there's quite a bit of variability in terms of contouring the tumor itself as well, even among the trials. Within your data set that you have picked up, have you noticed there's a particular pattern of relapse in the patient so far? Is it in areas, or is it a distance from the original or infill, or is it quite distant to the actual treatment?
In the patients who recurred after radiation, it was mostly local recurrence, and some patients showed distant recurrence, but only a few. And I'm not sure, but there were distant metastasis in about it was two or three patients who metastasized to their lungs. But basically it was the local infield recurrence.
Okay. And I think some of us had queries as to the dose given, right? Because in the past we used to give 54 in 30, and now recently the trials have sort of increased it to 60 in 33. I don't know if in your data set you did a comparison between these two doses, whether there was any difference in terms of, did you mention it, whether there's any difference in recurrence?
Sorry, I probably didn't make it very clear.
Sorry.
We did a analysis for the dose response relationship and observed a dose response relationship. And if you see here, actually most were around 60 or 54, but some patients were treated over 60 gray with hypofractionation or anything like that. Yeah. But if you do give more and more doses, the risk of local failure or death seem to decrease no matter which cutoff you use. So actually, but I don't know the optimal cutoff yet. So
thank you.
I think there is a possible benefit with increasing the radiation dose, since most of them are local failures.
Yes, thank you.
Thank you.
Hi, this is Adlinda. Thank you for the talk. It was an excellent talk. As you mentioned before, largely meningioma is grade 1. So with atypical meningioma, myself, I have limited kind of experience. but we have a neuro onco MDT. And with atypical meningioma, largely our neurosurgeon is not keen to refer for adjuvant radiotherapy, even when there is, especially when there is a post-tumor resection. For some patients, sometimes post-op changes is very difficult to sort of evaluate. So I'm just wondering from you and also from Prof. Gupta, you mentioned that upfront radiotherapy is within 6 months of surgery. If you actually repeat early MRI and to sort of evaluate the MRI again before you proceed, or you feel like it doesn't matter, you don't repeat MRI, you would recommend sort of adjuvant in the setting of post-tumor resection?
I'm not sure I got the question correct, but if I actually, every patient after surgery gets a post-op MRI within 48 hours in a national university. So by that, we evaluate the extent of resection and of course the surgeon's operation record as well. But once you plan to give radiation, then we do not do a additional MRI, because if we actually plan to give an adjuvant radiation, we give it within 1 or 2 months for the patient. So we do not do an additional MRI at that point.
How about Prof. Gupta?
Yeah, so at Tata Hospital also, those who are operated within our institute, we have a policy of getting an MRI post-operative done within 24 to 48 hours. But ours is a tertiary referral center, so we have a lot of patients that have undergone surgery outside and come to us for adjuvant treatment. Typically, they don't have an immediate post-operative MRI. So we always repeat an MRI at 2 months from the date of surgery. Even if we have an immediate post-op MRI, we also repeat a 2-month MRI just to be very sure that whether a GTR has been achieved or not. Of course, the surgeon's extent of resection, the Simpson grading is there in the surgical notes and the intraoperative impression. But I think an MRI at around 6 to 8 weeks after the surgery very clearly tells you that whether there is any residue or not. Also, the 6-month thing is the BN003, the current RTOG NRG trial, actually defines that 6-month window that any patient who has undergone surgery within 6 months with an atypical meningioma and has a gross total resection on a post-operative MRI done within 6 months of the surgery can be accrued on that study. So that's why the 6-month sort of window we call as upfront adjuvant treatment. Most people would not wait for 6 months. So as Dr. Chan said, that within 3 months most. So if we do an MRI at 2 months and we've decided to go ahead with the radiation, typically the radiation would happen within 3 months from the date of surgery. Does that answer your question?
Yeah. We also try to do within 48 hours of surgery. But sometimes with patient who has gross tumor resection, our neurosurgeon, because they see the patient first, and they immediately counsel to repeat MRI in some patients rather than straight away send to us for adjuvant radiotherapy. So yeah.
Yes.
But
I mean, as I said, for far too long, it has always been considered a surgical disease. So the neurosurgeons only generally that, I mean, I think things have changed in the last few years, but generally the neurosurgeons don't feel like giving radiation for meningiomas. They think that it's a benign disease. If it comes back again, they will take it out again. So yes, that philosophy is prevalent not only in your country, in India as well, and in vast parts of Europe and USA as well. There was a survey of the British neurosurgeons, and almost 70% of them said that they would never consider giving radiotherapy for meningioma, even if it was grade 2 or grade 3. So there is a strong bias against radiation as far as neurosurgeons are concerned for meningiomas.
I'm just wondering, I have another question. On the other hand, we do treat like grade 1 some patients with SRS or SRT. And in some patients with atypical meningioma, we also have treated with SRS, SRT, because our neurosurgeon is, on the other hand, is quite keen on SRS, SRT. So I'm just wondering your experience, Prof.
So the moment it is atypical meningioma, I think because you have to take a larger elective CTV volume, we don't treat them with radiosurgical fractionation. So only imaging defined small volume grade 1 imaging defined meningiomas. I mean, typically imaging defined meningiomas, most of the times, if you do surgery, they would be grade 1 tumors. So for that cohort only, we do radiosurgical treatment. Otherwise, grade 2 atypical meningioma, we always do fractionated treatment because the CTV volume that you need to take makes it a bit large, and we're not very comfortable doing single fraction radiosurgery for that kind of volume. Dr. Chan, what's the practice at your center?
Do you mean by the CTV volume?
Yeah. So would you?
I would never give a SRS for atypical meningiomas
exactly.
Because you have. I think you need at least 1 or 1.5 centimeters at least for the CTV margin, and sometimes I prefer using the 2 centimeter margin because almost all the local recurrences recur within the 2 centimeter, or sometimes some studies say 3 centimeters, but I think that a larger margin is needed, so I only use fractionated radiation.
Exactly, that's the exact practice that we have. The moment it is atypical, we don't use radiosurgical treatments.
Could I interject? Do you Dr. Gupta, do you have any experience with giving hypofractionated radiotherapy treatments? Because we do have a lot of elderly patients who can't go for surgery, and they suspected radiological atypical meningioma because of the rate of growth, and at the same time they can't go through 33 fractions of radiation treatment because it's quite often quite long for them. So do you have any recommended, or do you practice hypofractionated RT in these cases?
So in meningiomas, as I said, we don't really, I mean, if it's a small imaging defined meningioma, a single fraction would do. Even that is much lesser. Most of the time, those patients are observed actually. We don't follow hypofractionated radiosurgical treatment for meningiomas. At least at our center, we haven't been doing that. We would prefer to give them the 59 point, either 54 in 30 or 59.4 in 33 as per the RTOG NRG protocol.
Could I also ask Dr. Chan as well, because you did mention briefly about hypofractionated regimens, right? A 30 and 10 as well as a 40 and 15 one. Do you have any personal experience in your center as well for hypofractionated or moderately hypofractionated treatments?
Actually, I do not have a very long experience, so unfortunately, I don't have any experience on hypofractionation, but there are only very small data available to for us, and I think the data I showed you that the lower dose is very doesn't work well. So if the patient is so old or so the performance status is really not good, and he received GTR and it's atypical meningioma, then I would just probably do no radiation instead of lower doses. And for some patients with residual disease, I used hypofractionation to the residual GTV for just some dose escalation, probably up to about 66 gray, but other than that, I don't have any experience of hypofractionation.
That is the simultaneous integrated boost you would do, isn't it? I mean,
yes.
Yeah. So that we also do to residual enhancing nodules. Give it at 2.1 or 2.2 gray instead of the 2 gray or 1.8 gray. Yeah.
Thank you.
Dr. Wee, there's some There are some questions from audience, and there are 5 questions. And the first question is, what image you prefer before volume delineation postoperatively? Can you answer it?
Yeah, it's the T1 enhanced MRI, definitely. And I would like to have those PET modalities I have mentioned, but unfortunately we do not have the PET, so I have no experience using the PET.
Actually, I don't see brain tumor, but I see a lot of brain mets patients from lung cancer. And in lung cancer, we usually recommend spin echo sequence rather than prior gradient echo. And it suppress vessel signal. But as you introduce the PET imaging to distinguish the tumor signal except the vessel signal. And how about in meningioma MRI sequence?
Actually, because maybe the black blood sequence will help you a lot with METs, where you have to identify very small lesions. But normally in meningiomas, I think it's not really that necessary to use it, because anyway, we're going to delineate the GTV and then give a margin. So I'm not sure if we have to use that black blood sequence for meningiomas.
Yeah, but the DOTA PET actually helps in better delineation, and there's a recent publication on that as well. So you combine, of course, you have to have the MRI sequence, the volumetric contrast 3D FSPGR. We typically use the 3D FSPGR sequence, but increasingly we are now using an additional DOTA PET to sort of guide our target volume delineation for meningiomas. And sometimes you can be for surprise that you would not pick it up on the MR, but the PET would light it up.
Yes, I really want to use it, but unfortunately we do not have the PET in our institution.
Okay, let's move on to the next question. Which guideline you follow for volume delineation in conventional settings?
There is not just one guideline I follow, but I usually do not include the dural tail in the GTR, I mean GTV, and I just give a 1.5 margin for a more low dose CTV. And normally when I give a 5 millimeter or 1 centimeter margin for the high dose CTV, 60 gray and 30 fractions or something like that, normally the dural tail is included in the CTV. So my answer to this question is maybe the NRG RTOG guideline.
Okay, so not include dural tail to GTV.
Yes, but normally they're all included in the CTV.
Next question is, are there any patient or tumor characteristic that would make you favor higher dose, like 60 gray over 54 gray?
I normally just use the 60 gray and 30 fractions regardless, but I have used 54 gray because of the NRG trial, that the single arm trial published in the past, but these days I do 60 gray for every patient if I want to treat them.
Okay. Maybe next question is about SRS. And
can I make a comment there on the dose? Okay. So I think some of the optic nerve sheath meningiomas, I agree that most of them are grade 1, but some of the cavernous sinus and optic nerve sheath meningiomas, I think we need to reduce the dose to respect the tolerance. So we typically give only 45 to 50 gray for optic nerve sheath meningiomas. And for the most part, they are not biopsied, they are imaging defined, and they would typically be grade 1. And you just need a tumoristatic or a cytostatic dose, and you don't really need a very high dose. But for all atypical meningiomas, our current policy is to use 59.4 gray in 33 fractions. And if it is grade 3 meningioma, then we use 1630 with a simultaneous integrated boost of 63 to 66 gray in 30 fractions to the residual nodule as well.
Yeah, I definitely agree with Dr. Gupta. And if in my practice, if it's very close to the optic chiasm or the optic nerve, then I would just cut some part of my PTV and just prescribe 50 to 54, around 54 grade to meet those tolerances of the optic apparatus.
Okay, next question is there any experience with recurrent post-operative RT meningioma? It may be RT case or non-RT case. Any role for PET-based RT?
As I mentioned, I don't have a experience on PET-based radiation.
We are actually doing PRRT-based therapy for recurrent refractory meningiomas, and essentially, if they are very avid on the DOTA, there is a scoring sort of system by which one can decide whether they would respond to PRRT or not. I think in the last 2 years since we started, around 8 or 10 patients have received PRRT based therapy, and although formally we haven't sort of analyzed our results, what I can tell offhand is that there is a benefit as far as progression is concerned. I mean, these tumors tend to grow much slower once they receive the PRRT. Possibly the duration of that response is not very long, and eventually the tumor would progress. So, but I think if you don't have anything else to offer, that's a reasonable alternative.
How about RT recurrent case? Do you use same dose or?
So external beam re-radiation, you mean?
Yeah.
Yeah. So personally, we've had a bad experience with external beam re-radiation. And typically I am very, very reluctant to re-radiate unless it's more than 5 years from the first course of radiation. The 4 or 5 patients that I can recall where we did the re-radiation, almost every single patient landed up with severe post-re-radiation edema, necrosis, and had a bad time after the re-radiation. So typically we would avoid doing a external beam re-radiation, and that is where the PRRT actually sort of comes in, that you don't give that kind of toxicity with the PRRT.
I actually have re-radiated with conventional radiation of 44 gray or 45 gray, but the patient, of course, underwent surgery before the re-radiation, and it was totally removed. So I just went on to treat them like that. But if there is a gross mass remaining, then I think the 45 gray or 44 gray might not be sufficient to delay the growth or do tumor control. So but I did not experience a very severe edema or necrosis with 45 gray.
Okay, and other question is about constraints for brainstem or optic chiasm when you treat meningioma.
For the optic nerves and the optic chiasm, I definitely use 54 to 55 gray mostly, and for brainstem, I usually allow up to 60 gray for just a very small volume radiated, but normally I do a PRV around the brainstem and just restrict it to 54 to 56 gray.
Okay, and the last question is, how much do you give for low dose CTV?
Oh, I give 54 gray for those CTVs.
Are there any other questions or comments? Okay, if there are no more questions, I would like to announce to close the webinar by thanking everyone for your presence today. And we'll be looking forward to meeting you all on the next webinar. Can I close the webinar?
Bye.
Yeah, thank you.
Thank you very much for having me. Thank you.
Thank you,
Thank you.
Dr. Shaniki and all.
Bye bye all.